From the plains to the rolling hills, Oklahoma is a state that resonates with stories of resilience, determination, and pride. Welcome to Inside the 1581, a podcast of the Oklahoma Hospital Association. Together, we'll dive deep into the heartbeat of the great state of Oklahoma as we journey through the rich history, diverse culture, and the ever-evolving landscape within the 1,581 miles of border in our nation's 20th largest state. Each episode of Inside the 1581 will feature conversations with the many voices which help shape our state's future and our shared vision of improving health and healthcare in Oklahoma.
Thank you for joining us for another edition of Inside the 1581. I'm Rich Rasmussen. I'm the president and CEO of the Oklahoma Hospital Association, and I am delighted to have our guest today. We're going to talk about something that's really important. I think it impacts many, many lives, and we're going to be talking about stroke. And I just want to remind folks that in the United States, close to 800,000 people experience a stroke every year in this country. And it is one in which it is the leading cause of disability in America. And we're going to spend some time talking about that. And I'm delighted to have as our guests this week, once again by popular demand, for the fourth time, I think, we have Trent Bourland, who's the Vice President of Rural Health at SSM Health. Trent, thanks for joining us.
Glad to be back.
Fourth time?
Fourth time, I believe.
On Saturday Night Live, when you have hosted 5 times, you get the SNL jacket. Well, we have a jacket for you, but I can't give it to you because it has our old brand logo on it. Okay. So I'm a snob about that brand thing. So we have something else to give you. Hold on. So if you did not get one of our official cocktail tumblers with the OHA logo, this is what you get for fourth.
Now I have a set of 3.
That you do? Well, there you go. Well, that's because you gave it to the pack. So, all right, there you go. That's for being our 4th time here. I think I don't know who's been here more times than, or even close to that. So I think you've got it. You're setting the pace.
Jay or Bennett, I would
Jay
guess.
or Bennett, maybe so. That's true. That's a good one. So, anyways, we're glad you're here. We're also being joined by Eric Finley, who is the executive director of the Foundation for Healthy Oklahoma. Eric, thanks for joining us as well.
Yeah, thanks. It's exciting to be here, and especially to share this time with Trent, because this is a project that we've worked on together for quite some time, and we're at a really awesome place where things are coming to life from the work that Trent and I have done over the past couple of years to bring this project together.
And that's what we're going to talk about, Eric. And if it gets a little slow, we have our cowbell this week. So those of you who've listened to us many times, we've kind of teased a little bit about the cowbell from Saturday Night Live again. So Trent, out of his good sense of his humor, brought us a cowbell. And so we're going to mount this on a little stand. So when things slow down a little bit, we'll have our little drumstick to bring more cowbell into the conversation.
Like it.
So today we're going to talk about stroke. And certainly the work that our hospitals are doing around the area of Telestroke. And I'm going to start just a second with Eric a little bit on this, and we're going to get into the work that Trent's been doing to really evangelize what we can do to transform how we deliver stroke care in our hospitals. And so I'm going to start with you, Eric, a little bit about, this project that we're going to spend some time talking about is funded by TSET, the Tobacco Settlement Trust Fund. And those dollars are used in our state to advance a number of health initiatives. And most recently, TSET, working through the Foundation for Healthy Oklahoma, had awarded the foundation some resources to push out to our hospitals to really build on a telestroke program. Tell us a little bit about that and how we got there, and then we're going to talk, with Trent about the real advantages of a strategy like this and what we hope to see as the results.
Yeah, thanks, Rich. That's a great question. TSET has been a tremendous partner to the state in investing in our public health infrastructure to really address those leading drivers of chronic disease in our state. And so this opportunity came from the TSET Legacy Grant. This was a unique one-time investment by TSET. It's $150 million for grants focused on healthcare access, workforce development, nutrition, community-based prevention. And at OHA, we had been working, to really identify some sources to support growing telestroke in our state. And as I mentioned a few years back, this is a project that Trent and we had started mapping out. In the foundation here at OHA, we're essentially the public health arm of OHA, and we're really trying to address those leading drivers of death and disease in our state, especially where we can find those opportunities where we can find quick wins. And, I had conversation with Trent, and he was like, our critical access hospitals need telestroke. This is a blind spot for our state. And so we started working together, trying to provide education to hospitals and funders around the state. And this opportunity came up for the Legacy Grant, and we applied for it. And, one of the leading indicators in our project was to grow telestroke in our state. At that time, we had identified around 30 hospitals in the state, rural hospitals, that could benefit from a telestroke program. And we were fortunate to be, awarded a TSET Legacy Grant. I think there were 160 applications for that project. 14, applicants were awarded, and we were one of those fortunate sites that were awarded a grant for telestroke.
Well, it's incredible, what this is going to do for our rural communities. So, Trent, you overseeing the rural hospitals within SSM, and then previously as a CEO of a critical access hospital, I'm sure you have seen the opportunity that this presents itself, and you probably have seen in your career, missed opportunities where we didn't have that resource, and somebody who experienced a stroke left their community, and it created stress for the family as they traveled out of their community to be able to visit with their family member. All of those different elements of impact on the recovery of that patient. And now you've had the opportunity to work with Eric and really take this idea statewide. Tell us a little bit about that and how you see telestroke. Well, before we even go there, let's talk about what telestroke is. I mean, I think we missed that boat. Let's talk about what telestroke is, and then kind of walk us through your evolution of how this came to be.
Yeah, so telestroke is an opportunity for direct access to larger hospital systems that have neurologists on staff, or anybody that may be trained in neurology. And so, push of a button, and within a few minutes, you get one of these specialized individuals on the other side of the screen, and they can do some evaluations and look at some scans and things of that to determine if this patient is able to receive the thrombolytics, whether or not they need to be transferred to a higher level of care, all of the downstream points at that, and so it's an opportunity to try and provide the best access to care in these rural communities. And so, if you will, Rich, I'll just tell you
absolutely
at Cole County, we had a nursing home there that was adjacent to the hospital, and we provided management service to that. And so my first exposure to this was there was a lady who was a resident in our nursing home, and she had suffered stroke. And you could see it when you looked in her eyes. Excuse me. When you looked in her eyes, you could just see the desire to be what she once was, but she was trapped in this body that no longer worked. And so that just kind of got my mind working a little bit. And then fast forward a couple of years, there was an individual, and we know about Oklahoma weather, and so family friend, and she had suffered a stroke, and I'd visited with her, and she was in our emergency room at the time, and I was talking to her, and we were conversing back and forth, and it was that those I believe it was earlier in the year, and so we had ice storm. And so, our rotorcraft aircraft couldn't fly. And so ultimately that individual passed because of the complications with that stroke. And so then that really drove my conversations with Eric and gave me some momentum behind that to try and say, hey, what can we do in these hospitals? What can we do to facilitate quicker access to the care delivery for individuals suffering from stroke or having stroke-like symptoms, so that we can understand what the symptoms are, how to probably treat those, and then also going further upstream, looking at, community and education in the community to say, you know, if somebody is at home, a grandchild's home with a grandparent, and they say, you know, grandma's face is drooping, and what to do at those times, and how to identify it, and then also how to react in those cases. And so that's what we want to do. I think it's a top 5 killer in our state. And then for those individuals who do go on to remain alive, it's debilitating. And so trying to understand how can we speed that process up to treatment to try and reduce some of those long-term effects. And so there's another individual in our community, and not to name names or anything, but they were able to receive treatment quicker and just has a few deficits, but is still a functioning member of society. And so just trying to do that, because it's unbelievably challenging for families to care for stroke and individuals who've suffered from stroke. And so trying to treat it as quickly as possible. And so that's really what we're trying to get to, and try to help our state reduce expenses later down the line in the aftercare of those who suffer from stroke.
Well, I mean, clearly that, I mean, if somebody needs significant care post-stroke, I mean, they're no longer working, right? So their ability to contribute to society is certainly no longer there. Extreme expense, you know, if they become SSI eligible or if they're on Medicaid, clearly. And so we do see how a innovation like this that has been working for decades in many states, finally coming to Oklahoma, how it can transform not only families that might be victims of a member of their family that suffers from stroke, but certainly their communities as well. So talk a little bit about how this benefits, you know, the hospital in terms of how they're able to deliver services to their community, and what that says to their community in terms of how they can, create greater trust in their hospital's ability to impact their lives and the lives of their community.
Yeah, so that was one issue that we ran into is our hospital didn't have any stroke certification. And so what would happen was EMS would just bypass. If an ambulance was called and they picked that patient up, they would either call an aircraft to transport, or they would just completely bypass the hospital. And so I got to looking at some things and reading different types of material. And so then there's a thing called the bypass factor. And so what happens is it slowly begins to erode the belief and the understanding of what that hospital can provide. And so with these stroke certifications now, EMS goes to that hospital, the local critical access hospital, where we can begin to assess this patient and treat them. And so in some of those cases, that patient doesn't necessarily need to go upstream. And so what we can do is we can provide that patient inpatient care there locally, and start to deliver some therapy services. And so then that's a revenue generator in the community. And of course, the emergency room is a revenue generator. And then the part that excites me the most is in the critical access hospital is a swing bed program. So if there is an individual who has to necessarily go and receive further treatment for stroke, what we can do is get them back to their local community and start to provide them therapy services so they can get back to functioning to whatever point that is post stroke. And so that's partly what motivated me the most in conversations with Eric was trying to get that patient back home. We all understand that a patient heals better when they're closer to home, and so having access to that, it reduces the burdens on families, reduces burdens on the individual because they're not just stuck in a hospital somewhere receiving therapy and they're far from loved ones. And so that's the part that I really wanted to try and push and help and try to strengthen our hospitals through that.
So when we look at Telestroke, so first of all, if a hospital, let's say the program's funded from TSET here. So if the hospital has established the Telestroke program, they're seeking certification to be a stroke certified facility. If somebody presents, they have the technology in-house to be able to immediately begin the assessment with an experienced or with an expert outside of the hospital. A determination's made when they're in the hospital that yes, you can or we can effectively treat this patient in Cole County, for example. Now, if somebody needs treatment or ongoing care beyond the capability of that hospital, it now sets up a pathway to be able to transport that patient either by helicopter or ground to get them to the highest level of care. So for a community, if they see that sign that they're stroke certified, you know that that they can be treated there. And if they need a higher level of care, there is a process already embedded into how stroke is addressed in that community to take you to the highest level of care. Is that correct way of kind of sharing that?
Yeah, that's a much more articulate way of putting what I was trying to say. Yes, that is exactly what happens.
You did a great job. You did a great job. I was just trying to dumb it down for people like me. That's all I was trying to do. So go ahead. Keep going. You're good.
Yeah, and so worked on that with Eric through the foundation, just trying to find access ways. And then, with my move to SSM and St. Anthony Hospital and our managed hospitals, we have a partnership with the Regional Brain Institute. And so we're providing those services in our critical access and PPS hospitals. And there's 2 rural emergency hospitals that we're trying to get access to as well for these video telestroke consults so that we can provide that best level of care in that last mile.
Eric, these dollars have flown to hospitals already. Once they receive the funding, how does then that work in terms of how they set up their process for certification or determining who their stroke partner is going to be? How does that work out?
Yeah, that's a great question, Rich. It's pretty straightforward. We work with the hospital partners to really map out the whole project for them. And so, we have a point person here at OHA that walks them through the entire process. So setting up the evaluation protocol, the deliverables they're going to be looking at. For this example, Trent touched on it, but from a public health model, the door-to-needle time is the key measure that we're looking at of what's going to reduce morbidity and mortality. And so that, reduced treatment time is brain time or life-saving time. And so that model, we're looking at to help our hospitals set that up so that they're looking at it, that they're measuring it in the most effective way. We connect them with the Comprehensive Stroke Center of their choosing to provide the telestroke services. They will obviously provide them on the clinical training and measures that they need to implement the telestroke program. And we really help them with the public health side of it. Like Trent talked about, a huge piece of this, if you look at, national best practices, is a community engagement campaign. How are we engaging the community, not only on the new telestroke services that they have at the hospital, but awareness of stroke. Like Trent had mentioned, why is grandma's face drooping? What are the signs and symptoms so that, we can identify that rapidly and get those folks to treatment as fast as possible. We also work with them on engaging, their local EMS. Again, that's, making sure that they're aware that the program's there. And there's just a variety of, levels of engagement with EMS and hospitals across the state. Some it's tremendous, and then others, they're going to need more help. And so it's really an assessment, helping our hospitals assess their needs, and then putting an action plan in place for them, which is what we kind of do with our team here, helping guide them in this project.
And I would assume, too, that the education with EMS is really important because the provider needs to understand that their local hospital is now certified, has this technology. Otherwise, they may transport a patient 4 counties over and have the condition continue to worsen and actually have a worse outcome when they do come to the Comprehensive Stroke Center. So, Eric, what are some of our Comprehensive Stroke Centers off the top of your head? Can you name some of those?
Yeah,
so folks understand that some of our bigger facilities are comprehensive stroke facilities.
That's correct, Rich. So, the big comprehensive telestroke providers in the state, OU, Integris, Regional Brain Institute, which is, a partnership with Hillcrest, St. Francis is also a comprehensive stroke center. And so there's levels of stroke accreditation across the spectrum, but those comprehensive stroke centers are going to be the ones that have the ability to provide telestroke services to our smaller rural hospitals. And as you mentioned, when you were talking about that, and if we circle back to that door-to-needle time and that engagement with EMS, that's why that's so critical. Because if they are transporting them 4 counties over, that's delaying that door to needle time. And so the Telestroke program allows those patients transported to their local hospital to receive that clot busting medication in the fastest time possible.
Trent, I'm thinking, here we have our TSET funders helping us support a program that will impact countless lives. Whether you experience a stroke or a family member experiences a stroke, the fact that you have that in your community. And, this on the heels of, $6.7 billion in Medicaid cuts coming. And the uncertainty that's going to create all across our state, for that matter, $1 trillion across the country. And so in rural communities, which I would argue are disproportionately being impacted by these cuts, the importance of a program like TSET funding this so that there is some predictability of this resource being available as we roll into these cuts, which are going to ravage some service lines in hospitals. And for folks listening, service lines are those services that you offer. It could be maternity care, it could be oncology care. But in the area of what we're trying to do in stroke, the importance of these dollars probably now are more important than ever before because here's something that we can hold on to that has a definite return on its investment. And these are programs that, without the support of TSET, would potentially be at risk because of these, just incredible Medicaid cuts that are coming.
Yeah, definitely. And a lot of these small hospitals don't have the capital to invest on the front side of it, and so therefore they bypass the option to deliver that level of care. These state rules were changed in 2015, and it almost became an unfunded mandate. And so it's just something that needs to be highlighted. It needs to be accessed, and I'm happy to see that the TSET dollars are available. And then there's some rural health transformation dollars also that are going into Telestroke. And so just makes me happy that some of this work and these things that we've highlighted are finally attention's being given to them.
Now we look at here. We have how many hospitals are taking advantage of this program, Eric? Right
now, Rich, we have 22 hospitals that we have lined up that are going to participate. And I mean that I anticipate there could be a few more, but in the short window that we've had to really roll this out, we've had great engagement. And we have, 22 hospitals that are definitely in the queue to take advantage of this, again, all in rural communities. And when, you're kind of getting at Trent was really kind of getting at the point of it's the chicken or egg model. Sometimes it's like, well, the hospitals don't have the money up front, but, when we can help them with grant dollars, that's kind of teaching to the test. And so, it helps reduce that initial burden and then initial cost to figure out how to implement this, how to get reimbursement for it to make it sustainable. And we often see with many of these public health programs where we're getting our public health grants that we're providing, our hospitals. That's often the case. It is a case of teaching to the test, teaching them how can you implement this? How can we maximize reimbursement for this so it becomes sustainable?
And so I think what's the secret sauce to what TSET has done clearly is that they've made the dollars available on the front end to make these acquisitions, develop the programs, and because of that, you can start billing for it. Whereas oftentimes we get a grant where you've got to take on all the expense and then you have to start billing. So for a small hospital, that's kind of hard to do.
Yeah, the technical assistance is really what TSET's given us through this grant opportunity is to teach us the pathways, help us learn that road so that we don't just implement it and then it becomes a paperweight or something that collects dust because we don't properly know how to use it.
Right.
And so that's the part that I think is the most challenging in our rural areas is the technical assistance. We're struggling with staffing, we're struggling with knowledge in so many different in areas, and to be able to bring in experts on stroke and the signs and symptoms of to help, and then also on the revenue side, the collection and trying to make sure, and then facilitating bringing that patient back. So all great points.
And I think when we step back for a minute and look at the impact of this, where we know that 60% of the people who have a stroke are younger than 70 years old. So majority are just incredibly productive in society. and are having stroke. So the importance of having this literally in every community. Now, with the TSET resources, it's not going to ensure that every hospital has this, correct? So there's still opportunity to grow this. And so what are your thoughts about, how we can continue to grow it? And then maybe imagine for a moment if there was no barrier to any hospital having this. How do you think we would be performing as a state if there was no barrier to telestroke access?
Eric, you want to take that one?
Yeah, I think it's a great question, Rich. There's just with an opportunity like this where we have, in so many public health problems we face, we do not have. We're searching for the answer or the solution, right? There's still research or discovery. This is pretty straightforward. The driving down that door to needle time is literally the lottery ticket to reducing morbidity and mortality from stroke. And so when we have hospitals that have access to this, we have, EMS that's engaged in it. And we, again, as Trent said, in our rural hospitals, our, providers, staff wearing multiple hats, juggling multiple priorities, this really helps, provide a solution for that. And so I think it is, just a matter of timing, experience, ironing out, the kinks. And it's just a home run ticket for our state. Now, does that mean that we become the best in the nation? I hope so.
Well, and I know we had a conversation just the other day where we were talking about, where the Foundation for Healthy Oklahoma has leaned in areas we have pushed ourselves to being one of the best in the state. So if we look at where we are with the Oklahoma Perinatal Quality Improvement Collaborative, we ranked 8th nationally, 8th best in terms of mortality for moms when they deliver babies. So we are in the top 10 when it comes to that. I know as it relates to some of our focus area in lung cancer, we're in a good place. You were just throwing off some stats with me where they were impressive. What were those stats?
Well, those stats were around clinical tobacco treatment.
Okay.
And lung cancer is another area. As I mentioned earlier in the podcast, through the foundation, we're the public health arm of OHA, and what we're really looking at are those key drivers of death and disease in our state. So we mentioned, today we're talking about stroke. Lung cancer is another one where...
And there's a connection between smoking and stroke as well. There's a definite correlation.
For sure, right? And I think that's why TSET is so interested in this, because there's a connection, massive connection between TSET's two top priorities, which are really obesity and tobacco use and stroke. So, you can look at, there's just a direct linkage there. But yeah, so in clinical tobacco treatment, through TSET support over the past 10 years, we've driven down our rates by about 10 points. And so we still have a lot of room to improve. But if you look at a trend line, we're improving faster than any other state.
I think we had a couple A's. Give us the A's. We had a couple A's that you shared with me. What were those?
We did. We have, from the American Lung Association's a report card around, tobacco prevention and support. We were an A in public health funding. A lot of that is due to TSET's investment in public health funding around tobacco. We were an A in access and for treatment services. And this is due to our state quit line and then the support that our hospitals across the state are putting into developing clinical tobacco treatment support programs, like one that we developed with Cole County many, many years ago, which is how I got to know Trent. So those are areas where we're really doing really, really well. Areas where we're not doing so well are public health policy, things like taxes on tobacco products and state policies, regulating tobacco, where we're like an F.
Well, like vaping. Right?
Right.
Clearly vaping is out of control in the state, and that's, I think, where we score an F. So with all of the good we have to report, there's opportunity also to transform those indicators where we continue to perform poorly into a better place. And I think that's all of us, when we can get to, an aspiration where, nothing's acceptable unless we're getting an A, will get better. So whether it's reading or it's vaping, we want to get to a better place on that. Trent, you having spent your time working in rural healthcare and certainly now supporting your affiliates in rural healthcare, when you look at the challenges that they have, how do you feel going forward? Do you feel, affirmed that we're moving in the right direction? Not necessarily related to this project, but just in generally, or you still have some concerns? And do you think there are areas where, further investment is going to be necessary beyond RHTP? Because those are very specific. And for our listeners, the Rural Health Transformation Program, it's money that the federal government is making available to rural healthcare, not necessarily rural hospitals, but there are a lot of restrictions on it. The great thing with TSET is they took a bold idea and they provided the resources to deliver on that bold idea. So how do you see things playing out across the state?
Well, I would say that I'm an internal optimist.
Okay, that's good. If we're in healthcare, we're all optimists, right?
I do see positives, but to your point, yes, there's going to need to be additional investment post the $50 billion of the rural health transformation. It's just how it is. This $50 billion, if we went out and looked at our 39 critical access hospitals in the state of Oklahoma, and we're going to get 223.5, or we're getting 223.5 million. If you took that and spread it across the 39 critical access hospitals, it wouldn't be enough to lift them all to where they need to be able to serve their communities, and then beyond that, sustainability. So hopefully what we can do through this RHTP project is take some targeted investment, do some good facility assessments to understand where the gaps are at, and not just simply paint with a broad stroke and say, yep, everybody gets this. We need to understand the data more. We need to understand where the truest gaps are and invest in that. But there's going to have to be an investment post the $50 billion. It's just like what I'm going to equate to buying a car. You're going to have your oil changes. You're going to have new tires. You're going to have those services. We're going to have that in rural healthcare post RHTP and post the TSET investments. It's something that if you don't invest in it, it's going to wither and it's going to go away.
And I think you're spot on all of that. Rural hospitals struggle with the capital they need to continue to protect the investment they already have in their bricks and mortar. Certainly technology is a part of it. That's a great thing about what this TSET grant has done, is that it's provided the support for that technology for Telestroke. You've also have workforce challenges as people continue to age. How do you recruit them into a small community? And that's a tough one too for rural hospitals.
Yeah, I really like the grow your own effort under RHTP to get the example they gave in the program narrative was get an LPN upon graduation. How great will that be when you see these young people walking across a high school graduation stage, and now we can put I think it's a stash, whatever the term is, put it around, and it says LPN. They're graduating high school with an LPN certificate,
or maybe a paramedic,
lab assistant, all of these different things that we can train in our career techs here in Oklahoma, and just drive the needle forward in workforce and try to keep people locally, and then we can look at pathways to get them an RN or a higher level in their career ladder. So yes, I that's one that excites me. I hope we leverage it properly. I hope we utilize it properly. There are some great ideas, and hopefully we use them and leverage them properly.
Well, certainly there are synergies that come out of programs like that. So you see a synergy that's created through TSET's investment in Telestroke. Obviously, what we just talked about, Grow Your Own, creates a great opportunity to keep kids and to have an income that allows them to even support a family. When you look at it, hospitals, particularly in our rural communities, tend to be the high-wage employers. And so it creates lots of opportunities in their communities, and hopefully it keeps folks in rural communities and they don't flee to come to the urban areas, which is what we've seen in the state as well. So guys, as we wrap this up, so the Telestroke program is obviously has the opportunity to be transformational for certainly patients, but their families as well. And probably the next step, maybe we come back and talk about, is what we're going to be doing with the lung cancer screening, which is another program that I believe has been funded by TSET as well. So looking at these, this impact that tobacco has had on our state's health, and for that matter, our nation's health, the great work that's being done to push down on that, and how that is going to continue to transform the ability to deliver care, yes, but the outcomes of our care. And so maybe that's something, Eric, we can come back on and have another conversation about what we're going to be doing in that space. Does that make sense?
Yeah, that makes a lot of sense, Rich. I just, I wanted to add that, rural states are important. And so without rural, to have a rural state, you have to have rural communities. Yep. And healthcare is vital in these rural hospitals. They are the fabric of healthcare and health outcomes in our state. And so we have to, as Trent was saying, we have to find ways, innovative ways to partner with, to, bring new resources to support our rural hospitals if we're interested in improving the health outcomes in our state.
Well, this is an example where we're doing a little bit of everything.
Yeah,
right.
Rural communities, that's what I want to champion more than anything, is these small communities that have built our state and contributed to the development of our state. These small hospitals that serve them, whether they've transitioned to a rural emergency or they're at a critical access or they're a small PPS or even a regional PPS. Without those small communities supporting them, I don't know what the outlook for our state is, but I don't think it's promising. I don't think it's where we want to be as a state.
I couldn't agree more. We're the breadbasket of the world when you really look at it, from border to border, Canada to Mexico. It's where we live, and so whether you're raising cattle or you're raising corn, right?
Yep.
We're feeding America, and we need to be able to ensure that we nourish these rural communities like we expect them to feed the rest of us. And it's an obligation, I think, that we have to these rural communities all across the Midwest, and certainly, no exception here in Oklahoma. So we've been talking about Telestroke and the work that is being done in this project managed by the Foundation for Healthy Oklahoma. Eric Finley, Executive Director, thank you for being a part of our conversation. And Trent Bourland, he's been here 4 times now, and maybe we'll get him in the 5th time. Maybe that's where you get the smoker's jacket. Oh, we can't talk about smoking, right? Well, we'll get you like the blazer.
Yes.
With
members only, Rich.
Yes, working jacket, I think is what they're called today.
Yeah, working jackets. There you go. And just like you'll be right there with Tom Hanks in Saturday Night Live. There you go. Again, thank you guys for sharing a little bit about this with our listeners, and we'll look forward to further conversations about what we're doing to support our hospitals, but more importantly, to your point, Trent, supporting our rural communities is a big part of that. So as we wrap up, I want to say thank you for joining us in this episode of Inside the 1581. And I hope you enjoyed today's episode. But before we go, I want to give a huge thank you to our incredible sponsors at PYA. If they're listening or watching, I am wearing their shameless
Other side.
Oh, the other side. Very good. All right. Yeah. So I am wearing their gear today. So because it's kind of cold in this studio. But again, I want to thank them for supporting Inside the 1581, and for our producer Alex Taylor for making this podcast happen, and to our Vice President of Strategic Communications, Susie Wallace, who helps coordinate all of this for us. So please make sure that you subscribe and follow us and stay up to date on future episodes. You can do that on Spotify. You can do it and watch us on YouTube video. And then you can see that I now am showing my logo again on the right side here, or Apple Podcasts. I want to also mention the music that we're using is from the track Gunslinger by Ends of the Earth. We appreciate letting us use their music for our weekly or bi-monthly edition of Inside the 1581. So until we meet again, thank you all for listening. We do this because we want to communicate what we're doing to improve health and healthcare in Oklahoma.